Hi, and welcome to the CMH Family Medicine Top Tips and Tutorials. I'm Dr. Madeleine Muller, and we're continuing and talking about psychotic disorders, and we're going to specifically talk about how we diagnose schizophrenia, and obviously using our DSM, but it helps to understand schizophrenia a little bit before we actually get to the diagnostic criteria. And the reality is when you see somebody with psychosis, especially if they've had psychosis for a while or there's been symptoms or there have been problems for a while, you basically want to know, is there schizophrenia versus non-schizophrenia? And the implications and prognosis of schizophrenia it's very important to actually make the diagnosis. And we see too many patients still in our clinics, in our hospitals, that's got that, mental health care user diagnosis or that known psych patient diagnosis. And nobody's been brave enough to actually pin down, yes, this patient has got schizophrenia, and counsel the family about that. And I think one of the challenges is that we're all expecting that schizophrenia should be diagnosed by psychiatrists. But of course, the reality is, if you're working out in a district hospital or in a CHC or in a clinic, we don't have access to very many psychiatrists in places, for example, here in the Eastern Cape. And it's therefore going to be your responsibility as that clinician to actually make the diagnosis, manage the patient, and counsel the family accordingly. So with schizophrenia, always remember, first you want to make sure there's not a physical condition that's actually triggered that psychosis, and you want to make sure it's not substance related. So probably the most common reason for psychosis that we see coming through in our casualties, for example, is usually substance related, but they're fairly easy to pick up. Patients use the substance, went psychotic, we get him off the substance, he gets better. And so there we want to start looking also, there's a couple of other things we want to think about first that might confuse us. So the one is somebody having a mood disorder with psychosis. So this is somebody who's had depression, maybe they've had quite severe depression, and both depression and bipolar can end up having psychotic symptoms. So for example, if you have somebody who's had was quite high, he had bipolar, he got psychotic, was put on lithium and he recovered, that was probably part of his mood disorder and is probably not due to schizophrenia. It's also possible for some of your cognitive disorders like delirium or dementia to actually have psychosis on top of that, and that will also not obviously be schizophrenia. And then you do also get, and this is probably where psychiatrists are helpful, in some of your personality disorders, especially your schizoid or schizotypal personality disorders, where they might have periods of seeming actually delusional, and that can be confused with schizophrenia as well. There's also conditions that masquerade as psychosis that's not actually psychosis at all. So, for example, somebody might have a very strange and odd and bizarre specific phobia, which you can't actually argue them out of, but that's not psychosis. Intellectual disability. So some people, if they've got, especially if they're struggling with verbal skills, they may speak or act bizarrely. Some people actually might feign delusions or hallucinations to get admitted. And those are people obviously who are mentally unwell, but they're not actually psychotic. And then you get people who are just plain making it up because they want a grant or they're trying to get out of their prison sentence. So these are just things to keep in the back of your mind. So schizophrenia, just a few little things. So it's up to 1% of the general adult population in some studies. That's actually quite a lot of people that have schizophrenia. Tend to be more, the males tend to present more than women, and they present quite young. And there's usually a family history. So this is a genetic disorder, and usually it begins in the early mid-20s, but even when you take the history, you will find there's already clues from when they were younger. So just a word about that. If somebody's over 40 years old and for the first time they are presenting with a chronic psychotic disorder, it's unlikely to be schizophrenia. It is possible. Don't exclude it completely. It might also be missed for years, but you might need to go and look a little bit further and make sure it's not actually something else. Very important is when somebody has schizophrenia, this is a lifelong condition, and patients will improve. We can manage it quite well with treatment, but we're not going to get them to a pre-morbid state. The antipsychotic drugs need to be taken lifelong. They also have side effects, not the greatest things, and this is quite a big implication for this person's life. So if you take a bit of a history and you actually look at how schizophrenia develops over time, there's already a phase 1, way before they even start having any symptoms of psychosis, where people would have said the patient might have been quite withdrawn, might have been quite peculiar, was slightly odd at school. And then there's about 3 to 6 years. That's quite a long time where we talk about pre-psychotic experiences. So they've got a little bit strange in their thinking, maybe a little bit strange in their speaking, the way they behave, but none of it actually completely fits that psychotic picture. And we're not yet talking about negative symptoms. So there's no psychosis yet, but the patient's cognitive functioning might be a little bit different. And then gradually, over a 6-month period, that's the definition of schizophrenia, the patient starts developing very clear psychotic symptoms. So they can be involved with delusions and hallucinations right from the start, or a big part of the 6 months might be just having very peculiar beliefs or these negative symptoms. And then on top of that, you have these episodes of delusions and hallucinations. So schizophrenia has a huge impact on people's lives and on lots of different aspects. So, for example, we also know people with schizophrenia for different reasons quite often have got comorbid metabolic syndrome. That's both the lifestyle, difficult to manage your lifestyle if you are struggling with cognitive functioning. Medication itself doesn't help. It's a very high level of tobacco use in our patients with schizophrenia, with all of their subsequent problems. But they also have other additional cognitive issues. So they might have cognitive dysfunction, just very easily distractible, very easily disorientated, struggling with learning and memory. They might struggle also with dysphoria, so have more anxiety and more depression, maybe inappropriate affect. And as we've said, one of the big features is that they don't, even when they have been treated and even when they're not psychotic, they might struggle to have actually insight into their illness, and therefore that makes it difficult in terms of medication. And psychosis has a huge impact on the functioning of both the patient and the family. And actually part of the diagnosis is saying that the patient is materially impaired in their social or occupational functioning. Most of these patients never marry, they're not in long-term relationships, they don't work, or if they do work, it's menial work that they can't sustain. And what's interesting is that of all the psychotic disorders, this is the only psychotic disorder where you cannot diagnose somebody with schizophrenia if they are functioning well in society. And a very high suicide rate, so much higher than in our usual population, and especially when newly diagnosed in young men, they are particularly vulnerable. So let's just look at the DSM V criteria. There's 2 or 3 slides on that. So very simple. You are looking at 5 possible, and we talked about those 5 symptoms earlier, and they need to have had at least during that 6 months, they must have had at least 2 or more during a whole 1-month period of time. So either delusions or hallucinations or disorganized speech. And so at least one of those, and then grossly disorganized or catatonic behavior or negative symptoms also as part of that list. So they must have at least one of delusions, hallucinations, disorganized speech, but out of the list of 5, there must have been at least 2. And this psychotic behavior, we are talking about behavior that's grossly abnormal. And we mentioned earlier, it will actually interfere with their life and they will have very little insight into what's happening. It doesn't really matter whether the behavior or whether the delusion is bizarre or not. It doesn't actually make any difference to either the diagnosis or prognosis. So you'll see it's not part of the criteria and you'll just put it in as a signifier in your diagnosis. So they have this thing of it has to be 6 months. So that doesn't mean the patient must have had frank psychosis, those main positive symptoms for 6 months. There must be at least 1 month of those psychotic symptoms, but a significant time of that 6 months, they also have these prodromal or residual symptoms. So these negative symptoms that we mentioned earlier. So they are not functioning during that 6 months time. And sometimes you actually have people who've been brought in that's been living on the street or has been wandering around and not actually been able to engage with their usual lives. And then as I've mentioned earlier, this marked decreased level of functioning is part of the criteria. You can't diagnose somebody with schizophrenia unless they have that. Of course, you have to rule out any other mental health conditions, so schizoaffective disorder. I've mentioned that in the first tutorial. Usually that'll be diagnosed by psychiatrists. So if you're looking at somebody and you're not sure whether this is mainly mood or mainly schizophrenia, you might have to get another opinion, and just to make sure it's not a mood disorder with psychotic features. You also got to check the medical conditions, and you also got to check whether there's not substance abuse as part of your workup. Just a word about autism spectrum disorder. That might make the diagnosis of schizophrenia more challenging, and need to make sure that you're not taking some of the neurodivergent behaviors as part of your schizophrenia diagnosis. So it's sometimes helpful to think about when it's probably not schizophrenia. And the big thing is if it's less than 6 months, probably not. And if there was a precipitating factor, so something traumatic happened, and then the patient had this episode of psychosis, like we have in brief psychotic disorder. Schizophrenia is not usually, although stress can make it worse, there's not usually somebody who's been completely well, and then something happened, and then went psychosis. That's unlikely to be schizophrenia. And there's usually, when you look at the previous course of the illness, if somebody's had a psychosis in the past and they completely recovered and they've been completely 100% fine, that's probably not schizophrenia. Schizophrenia has these prodromal period and these negative symptoms in between. So you will look at how well have they always functioned. And again, a well-functioning person who suddenly becomes psychotic, less likely to have schizophrenia. I hope that's going to help you make your diagnosis a little bit easier. And in the next tutorials, we'll start talking specifically around the management.